I'm going to kind of cover briefly some of the major lobes, and then we'll move into a little bit of function, some of the major functions in these lobes. So starting with frontal lobe. So when you think about the frontal lobe, imagine that you're putting your palm on the patient's forehead and you're laying your first 3 fingers over their frontal lobe. And that's a good way to think about the anatomy of the major gyri of the frontal lobe. So looking at my cartoon here, you can see there's 2 sulci running in an AP direction that divide the frontal lobe into a superior frontal gyrus, middle frontal gyrus, inferior frontal gyrus. And those are going to run perpendicular to the precentral gyrus. So here's that superior, middle, and inferior frontal gyrus. And then the inferior frontal gyrus is just a little bit more complex. So you might break it up into these 3 parts: pars opercularis, pars triangularis, and pars orbitalis. So I said those 3 run in an AP direction perpendicular to the precentral gyrus, right in front of the central sulcus, which is right in front of the post-central gyrus. You have to think about the medial surface of the hemisphere when you're thinking about the frontal lobe as well. So the medial surface is formed by the medial surface of the superior frontal gyrus, anterior half of the paracentral lobule, and the cingulate gyrus. So here we go on the medial hemisphere. You can see this very large superior frontal gyrus, the medial portion of that, and that comes back. And here is that paracentral lobule, and the anterior half of that is the end of the frontal lobe there. And just to remind you, the cingulate and the superior frontal gyri wrap around the genu of the corpus callosum here, and the periterminal and olfactory gyri sit below the rostrum of the corpus callosum in front of the lamina terminalis. So I'm sure as you read about surgical approaches into the 3rd ventricular space, there's a well-described approach that goes through that lamina terminalis. Temporal lobe. So same thing. If you imagine laying your first 3 fingers about where the temporal lobe would be, that's a good way to think about the basic anatomy of the temporal lobe here. So there's 2 transverse sulci dividing it into a superior temporal gyrus, middle temporal, and inferior temporal gyrus there. Transverse or Heschel's gyrus runs anterolaterally over the superior aspect of the superior temporal gyrus. So Heschel's gyrus is kind of up here on top of the superior temporal gyrus, kind of tucked in the sylvian fissure. A little bit more. So medial, you also have to think about the medial surface of the temporal lobe. So that's formed by the rounded medial surface of the hippocampal gyrus and the uncus that you can see in the picture down here. There are sort of 3 major gyri or strips. There's the parahippocampal gyrus inferiorly, the dentate gyrus more medially, and then the fimbria of the fornix. The parahippocampal gyrus projects medially along the edge of the tentorium and forms a large part of the basal surface of that temporal lobe. The uncus is the medially pointing anterior part of that parahippocampal gyrus. And we'll look at that in some pictures down the road here. All right, parietal lobe. So the parietal lobe back here consists of a large transverse intraparietal sulcus that divides it into a superior parietal lobule and an inferior parietal lobule. And for the most part, we think of the inferior parietal lobule consisting of that supramarginal gyrus right here, which caps that sylvian fissure, and then the angular gyrus that caps that superior temporal sulcus. All right, occipital lobe. The occipital convexity is not as well defined and well separated by clearly defined sulci. Most consistent sulcus is the lateral occipital sulcus that divides the superior and inferior occipital gyri, and we'll look at that from the medial surface in a second as well. So medially, the occipital lobe is separated from the parietal lobe by a parietal occipital sulcus. The calcaneal fissure extends forward and divides the occipital lobe into the cuneus and lingua. On the medial surface of the hemisphere, I just wanted to point out this one particular structure, the marginal sulcus, is a radial sulcus off of the end of the cingulate sulcus that separates the paracentral lobule from the precuneus. So if you think about that cingulate sulcus coming back, it swings up and becomes a marginal sulcus. And I just point that out because a lot of times on MRIs, when we're looking at pathology, we're trying to figure out where the primary sensory cortex for leg is and the primary motor cortex. And if you can find that marginal sulcus, that loops up right behind that primary sensory cortex. So it's usually a pretty prominent sulcus that you can find, and it can help you find this eloquent cortex. All right, so quick overview of some of the cortical structures. Of course, there's a lot more to it than that, but that's a quick introduction to it. So what about some of the functions of some of these areas we just quickly touched on? Primary sensory. So the primary sensory cortex is here in this kind of bluish color, right behind the central sulcus. That primary sensory cortex located in the postcentral gyrus of the parietal lobe and posterior paracentral lobule. So you're going to see references to Brodmann areas. I think these are a little bit outdated, but since they crop up a lot, I left them in this lecture. So this primary sensory cortex is Brodmann areas 1, 2, and 3. The sensory cortex receives fibers largely from the VPL and VPN nuclei of the thalamus, convey general sensory like touch, pain, temperature, proprioception, and vibration, and also receives convisual fibers from the contralateral primary sensory cortex through the corpus callosum. So remember, the primary sensory cortex has a sensory homunculus that represents that contralateral half of the body. And so there's a good reminder of what that homunculus looks like for the somatosensory cortex. You can see where hand and face are located a bit more laterally, leg more medial. So there's a disproportionately large representation of face, lips, hand, thumb, index finger, places where you want really high discriminative touch. Pharynx, tongue, jaw, they're more ventral, leg, and foot on the medial surface, just above the cingulate gyrus. And face and tongue are represented bilaterally. So we think of this as primarily representing the contralateral side, but keep in mind that face has a very strong, robust bilateral input. And that's why you can sometimes resect face sensory or face motor, and the patient may not have any deficits. The problem, though, is once you get beyond that into the rest of the primary motor cortex, you start to have significant obvious deficits. Primary sensory cortex, so ablation of this area will result in immediate loss of sensory modalities, but pain and temperature sensations can return, and that's thought to be primarily due to the thalamic input. Therefore, you're left with complete loss of discriminative touch, proprioception, but you can continue to have a crude awareness of pain. I'm sure you probably have come across thalamic pain syndromes, especially, for example, in stroke patients. So when we think about all these sensory cortices, remember there's always association or secondary cortices for all of these primary sensory cortices. So there's a very robust sensory association cortex for primary sensory. I'm going to let you guys just read through some of that, but just keep the concept in mind, and then you can read through this to kind of think a little bit more about the relevance of it with regards to function and what happens when you lesion those areas. How about the visual sensation? So primary visual cortex. So we've introduced that a little bit back here in the occipital lobe. So the calcarine gyrus on the medial surface of the lobe is split by the calcarine sulcus. That's Brodmann's area 17. You probably have come across this prominent band of white matter called the band of Genori, this very thickened layer 4 in the cortex. So remember, most cortex layers have 6 layers. The visual cortex receives fibers from the lateral geniculate. Each visual cortex receives input from the ipsilateral half of each retina, representing the contralateral visual field. So if you look at the color schemes here, just to point out the area below the calcarine fissure that corresponds to the visual field superiorly, and then as you get closer to the pole of the occipital lobe, you get closer to where central vision is located. And then remember that it represents the contralateral visual field. So this is the right hemisphere, and this is showing the left visual field for those. So I'm sure you all remember, the entire visual pathway. So this is important to learn very well, because it's one of the longest pathways through the brain where a lot of pathology can interfere with it. So if you have a good grasp of that visual pathway, and you can understand the visual deficits that come from pathology along that pathway, then that can really help you localize lesions. And so I'm sure you all will recognize this sort of chart where they've mapped out the visual pathways, where it decussates, where it comes back to the lateral geniculate nucleus, and then you have the optic radiations that swing out into the temporal lobe and that swing up into the parietal lobe. And if you have lesions at various places, you're going to have a very characteristic visual field defect. So this is a very important bit of information to study and learn very well. And so I encourage you to spend a little bit more time on this. So as a couple examples, E represents those optic radiations that swing out into the temporal lobe. And so if you have a temporal lobe lesion out there, you get this characteristic visual field deficit, or this pie in the sky deficit, a superior contralateral quadrantenopsia. F is meant to represent a lesion in the optic radiations as they swing up into the parietal lobe. And so F gives you this sort of visual field defect where you have a inferior quadrantenopsia on the contralateral side. So anyway, make sure you know these pathways very well. It can go a long ways in helping you localize lesions after examining patients. So a bit more about the primary visual cortex. Lesions produce visual field defects in the contralateral visual field. Lesions inferior of the calcarine fissure give you a contralateral quadrantenopsia. Lesions of the whole visual cortex in one hemisphere result in loss of vision in the contralateral visual field. If the lesion is vascular, for example, occlusion of a PCA, that patient might actually have macular sparing or sparing of their central vision because that very critical eloquent cortex receives collateral blood supply also from the MCA distribution. So again, there's secondary visual areas, and I'll let you guys study that on your own time. How about auditory cortex? So the primary auditory cortex is located here, like I mentioned earlier. That's the transverse temporal gyrus of Heschel. Brodmann area is 4142. It's in the temporal lobe within the sylvian fissure. So you really need to open up the sylvian fissure to access it. That receives input from the medial geniculate nucleus, receives input from both ears, but predominantly the contralateral. Cortical organization is columnar, based on isofrequency strips. So if you really dive into the microanatomy, most of the sensory cortices have some sort of columnar structure from superficial to more deeper areas in the cortex. You're probably most familiar with that 6-layer structure that you see in the visual cortex that's very well mapped out. Well, there's also a similar columnar structure based on frequency for audition. And there's a similar theme with some of the other cortices. So there are several areas that have important connections to the primary auditory cortex. Lesions of the auditory cortex result in impairment of sound localization. So that makes sense. You'll have decreased hearing bilaterally, but a little bit worse on the contralateral side. And again, there's association cortex around that primary auditory cortex. There's a gustatory cortex located here for taste. So that's the cortical receptive area for taste in the parietal operculum, near the sensory areas for tongue and pharynx. So that kind of makes sense. Seizures in that area are associated with gustatory hallucinations. That area receives input from the VPM of the thalamus, and lesions there can affect taste, as you might think. Olfactory cortex. So this is often referred to as the piriform cortex, located here, and the periamygdaloid area located in the medial tip of the temporal lobe. And that receives inputs from the lateral olfactory stria. So there's the olfactory bulb tract coming back. There's a lateral olfactory stria as well as a medial olfactory stria. It's the only sensory cortex in which fibers reach cortex without passing through the thalamus. And of course, you might remind yourself of the very robust connection of this sensory cortex with that very complex limbic system that you've studied.
Hey everyone, Ryan Rad here from Neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.